Hello everyone, give me a confirmation whether I'm live, whether you're able to hear me loud and clear. I guess there will be a slight delay between me streaming from here and you guys getting my feed. It appears that I'm live. So today this is going to be a tiny topic. We will hardly spend 20 minutes understanding weight loss. Weight loss is one common complaint that our patient comes to hospital, and studies have shown that 1/3 of the patients hospitalized for some indication also have complaint of weight loss. So obviously weight loss need not always be intentional, right? So today's attempt is to identify patients having unintentional weight loss and how to evaluate. But before that, let me emphasize why it is important for us to be good clinicians based on a recent experience I had. Just a couple of days back, I was working out in the gym and all of a sudden I passed out in the sense I lost my consciousness. And my fellow gym mates later told me that I was unresponsive for few minutes, and during that period I had lost responsiveness and then again gained responsiveness and then lost responsiveness again. But during that period of 10-12 seconds where I had gained responsiveness, I told them that I am going through hypoglycemia and please get me some liquid glucose or IV glucose, and then I passed out again. And then this is told to me by fellow gym mates who attended to me. I have no memory of this event. I only remember losing the consciousness and then waking up lying on the floor of the gym. Okay, now I learned two lessons from this experience. Lesson number one, if you need not always be even a doctor to help someone who is going through some emergency situation. And fortunately for me, my fellow gym mates could recognize that I was going through hypoglycemia. How could they recognize? 4 months ago, I had done a half an hour session discussing with them the importance of emergencies in gym, which is now become a graveyard, right? Every now and then you hear a news that some film actor, some athlete while working out in the gym died. So having understood that, okay, there is a gravity of emergencies that can happen in the gym, I had spent half an hour educating fellow gym mates who work out during the same time period as me. And then I had told them to recognize, how to recognize seizures, how to recognize hypoglycemia, how to recognize myocardial infarction on clinical grounds, on rough sketch. Okay, so they remembered that if someone is losing consciousness, at the same time he is profusely sweating and he is having tremors, it could be hypoglycemia. So they had remembered that. So when I was about to lose consciousness, they had arranged a chocolate and made me eat, which I don't remember. But still I lost consciousness because chocolate, obviously fat loaded, takes some time to kick in and reach my blood. But after some amount of chocolate probably had reached my blood, I had gained my consciousness. And during that period when my brain was still going through hypoglycemia, I was still able to recognize what I was going through and communicated to them saying that I am going through hypoglycemia and I need some liquid glucose. Right, so the lesson number one, disseminate knowledge, be able to recognize medical conditions. Lesson number two, the more you invest in learning subject medicine, right, it will help you as well as your fellow mates and your patients live longer, live better, right? Okay, so with that backdrop, good evening everyone. So we'll start with today's topic, which is about approach to weight loss. I will not take more than 20 minutes, but before that, our learning is not complete if we don't spend time on the previous topic, right? So we will do some MCQs on the previous topic and then we will get going with today's topic. So here is a question. Which of the following tool is recommended for assessing degree of dyspnea in COPD cases by GOLD guidelines, which I'm sure most of you will be familiar with, right? So which is the guideline recommended by the GOLD guidelines for assessment of degree or severity of dyspnea in COPD? I'm waiting for your comment, guys. I'm very sure that most of you will be able to answer this. Right. So for respiratory disorders, we prefer modified medical research council grading. For cardiac disorders, we prefer NYHA, right? And can anybody tell me what is this last option? Modified Kupusamy classification. Where do you use it? Yes, you're absolutely right. The answer should be option B, MMRC grading. Very good. Krishna Rathod, Nuseba, Abrak, all of you are right. Manpreet Singh and Parneet Singh, absolutely right. Okay, if you're in second year or third year, you might be familiar with this term, Kupusamy classification, right? Where do we use it? Very important tool indeed. We use this Kupusomi classification for assessing the socio-economic status. For what purpose it is used? Yes, right. It is used for, this is for assessing socio-economic status. Why that is important? Because socio-economic status is such a subjective thing. Like you ask a patient, do you feel you're rich or you're poor? It's subjective, right? Now I have everything, but I still feel I am poor. And you might find someone who just has 1,000 rupees in his pocket and nothing more than that. That's all he has, but still he may be feeling rich. And some of you may be thinking like, I don't even have 1,000 rupees, but still you may be feeling rich. That's obviously subjective. Whenever we have subjective things, we need to make them objective by using tools. So we use this modified Kupusomi classification for assessing the socio-economic status. Okay, good. Now there's a second question here. We have to identify the wrong match. Platypnea, orthopnea, PND, trepopnea and corresponding matches. Okay. So now platypnea, hepatopulmonary syndrome, is that the right match or wrong match? Nilofer and Nuseba, absolutely right. It is used for assessing the socio-economic status. What platypnea refers to, as I have told yesterday, platypnea is opposite of the orthopnea. In orthopnea, patient feels short of breath when he lies down flat, or what you call as recumbent posture. And when he sits upright, he feels relatively relieved. Platypnea is exactly opposite. When I sit upright, I will feel short of breath. When I lie down, I will feel relieved. So in what conditions we see that? I told you two examples to remember. One is ASD, second one is hepatopulmonary syndrome. So this is a right match. So this is true. Okay. Orthopnea, right heart failure, is that the right match? What orthopnea indicates? Orthopnea indicates left heart failure, right? So when right heart fails, congestion happens in your neck veins and liver. When left heart fails, congestion happens in the lungs. So when there is congestion in the lungs, we experience orthopnea. So I think Parnit Singh, yes, absolutely right, and Nuseba Abrak, absolutely right. Orthopnea is the wrong match. We don't see orthopnea in right heart failure, we get it in left heart failure. PND, left heart failure, as we know, is right match. And similarly, trepopnea, right? What is trepopnea? When you lie down in one lateral position, you feel short of breath. That can happen when you have pneumothorax or massive pleural effusion. So this is also the right match. So these are all true matches, but option B is wrong, as we know. Okay. Now I have one last question before we go to today's topic. Which of the following does not contribute to the pathogenesis of orthopnea? Which of the following does not contribute to the pathogenesis of orthopnea? Okay. Now let us go one by one. Option A, increased venous return on lying down. Does it play a role in the pathogenesis of orthopnea? Why orthopnea happens in left heart failure? Because patients with left heart failure already have congested lungs. When I lie down, there is increased venous return, right? So that extra blood coming to the right side of the heart will eventually land up in the lungs and worsen the congestion, and that will definitely make them feel more short of breath, right? So there is definitely a role of increased venous return on lying down. Okay. Worsening lung congestion on lying down, absolutely right. Means increased venous return causes orthopnea because of worsening lung congestion. So this is also true. Statement A is true, statement B is true. What about statement C? Return of edema fluid to circulation. Does it have a role to play in pathogenesis of orthopnea? Please remember, we have discussed the differences between orthopnea and PND. Main difference is in orthopnea, as soon as you take a recumbent posture or as soon as you lie down, you feel short of breath. And as soon as you make yourself upright, the shortness of breath gets reduced. What happens in PND? You have to go to sleep, you have to fall asleep. Somewhere around 1.5 to 2 hours later, you will wake up with shortness of breath. And once you wake up, again, the relief is not immediate. It is going to take 30 to 45 minutes, right? So now tell me, does edema fluid play a role in the pathogenesis of orthopnea? Can edema fluid come to the veins and then to the heart immediately on lying down? Have you seen any patient where like they were edematous, they lie down and the edema disappears? No. Over days, edema fluid is accumulated in the lower limb because of gravity. Once I eliminate the impact of gravity, it will take several hours for that fluid to come to circulation, not immediately. So it does not play a role in the pathogenesis of orthopnea. It plays a role in the pathogenesis of PND. So for us, the correct answer here will be option C. This is false. right? So this plays a role in, this is important in pathogenesis of PND and not for the orthopnea. Okay, so that's it for the revision. Now we will start with today's topic, which is approach to weight loss. Just like how cough and shortness of breath are common complaints, weight loss is also one of the common complaints that you will encounter in medical patients. If you spend 2 months of your bedside postings, I am very sure that at least 10 patients you will encounter who are complaining of weight loss. And the first and foremost important thing when someone complains of weight loss is to understand whether that weight loss is intentional or unintentional. Today's generation is having fad of lean body, fitness, right? They're all enthusiastic about fitness and they may be making an attempt to lose weight intentionally. For those individuals who are losing weight intentionally, I have no concern, right? They can be on their track. But if someone has lost weight unintentionally, it is a concern. It always indicates that there is an underlying major disorder. Just like how dyspnea always indicates that there is an underlying major disorder, unintentional weight loss also indicates that there is an underlying major disorder. But one problem comes. See, for example, I come to you and say that, sir, last month I was 65.5 kg. Today I am only 65 kg and I am worried about it. Is that a relevant weight loss or is it not? We need to have an objective understanding, right? When I can consider it as clinically important weight loss. So for that we have to be very clear that clinically important weight loss refers to weight loss of more than or equal to 10 pounds, 10 lbs, which is approximately 4.5 kgs over a period of 6 to 12 months, over a period of 6 to 12 months, unintentionally. Then we will call it as clinically relevant or significant weight loss. So patient has no intention to lose weight, he is carrying out his routine activities, he is having his routine diet, but despite that over a period of 6 to 12 months, he has lost more than 10 pounds or 4.5 kgs of his body weight. Then we will call it as clinically relevant. This is one definition that we get in Harrison. Let me also take you through what else Harrison says, what else can contribute to be called as clinically significant weight loss. The second point he mentions is if patient loses more than 5% of his body weight over a period of 6 to 12 months, then also we can consider it as clinically important weight loss, right? So there are 2 points here. Either patient has lost more than 10 pounds in 6 to 12 months time, or he has lost more than 5% of body weight over 6 to 12 months of time. Then we will call it as clinically important weight loss. And these are the patients which require further evaluation. Okay, so now we have defined it. This is a very, very important definition. This is something that every time you say to the examiners or bedside discussion, you mention that, sir, this patient is complaining of weight loss. The examiners will shoot this question. Is this weight loss clinically relevant or important? And you should be able to defend yourself saying, yes, sir, this is clinically relevant because patient has lost more than 10 pounds or his earlier body weight was 60 kg, now he has become 50 kg, so he has definitely lost more than 5 kg over a period of 6 to 12 months, and that is why I consider it as clinically important, significant or relevant weight loss. Okay. Once you identify that this patient has got a relevant weight loss, the next thing is what could be the cause. There are 4 major categories of weight loss where there is unintentional weight loss. UWL here refers to unintentional weight loss. First and foremost concern is always malignancies, right? Other than that, chronic inflammatory as well as infectious disorders, metabolic disorders and psychiatric disorders can cause unintentional weight loss. Okay. Now, when it comes to malignant neoplasms, can you name which cancers are likely to cause weight loss? See, not all cancers cause weight loss, right? You will see a lot of patients with skin cancers. Do they generally develop weight loss? Probably not, until and unless it is an advanced stage. But there are several cancers who get recognized because patient first presented with unintentional weight loss. Doctor recognized that this patient's weight loss is clinically important, investigated and then got to know that, okay, he is having a cancer. So tell me those cancers which can present with weight loss as a complaint. Any cancer in the last stage will definitely cause weight loss. Okay, so that includes carcinoma of the stomach, okay, then carcinoma of the lungs, carcinoma of the ovaries, okay, then breast carcinoma and other solid tumors, Yes, renal cell carcinoma can also cause significant weight loss. That is why in simple words, majority of the solid tumors can cause weight loss. Can anybody tell me what could be the mechanism behind weight loss in patients with malignant neoplasms? What could be the mechanism? See, 20% of cancer patients, like 1 in 5 cancer patient dies because of what you call as cancer induced cachexia, which is nothing but weight loss caused by cancer. Right, what is causing the cachexia? Cachexia is nothing but weight loss, loss of lean body mass caused by cancer. What is the underlying mechanism? There are 2 mechanisms which contribute. The first mechanism is increased calorie demand, because tumor cells, as we know, right Krishna Rathod. So the tumor cells are metabolically more active because they are dividing continuously, unlike your regular cells. So when a cell is dividing continuously and growing, it needs more glucose. So the tumors, its requirement will outpace what we are eating. I may be eating 2000 calories, but because of the presence of tumor, I may be requiring 3000, 4000 calories. And because I am not able to meet the calorie requirement, I will start losing the weight, increased calorie demand. And there is a second mechanism. There is increased inflammatory cytokines, which have very complex role. Inflammatory cytokines like interleukin 1, interleukin 6. As you study in pathology, you will know more list of inflammatory cytokines. These cytokines have a tendency to suppress appetite. At the same time, they will slow down the gastric emptying. They will also have an impact on the basal metabolic rate. They can increase the metabolic rate. So when metabolic rate is high, even when we are not doing any physical activity, our tissues are burning more calories, and that is how we end up losing the weight. Midoriya's Izuki, I have noticed that we are sorting out. I think there is a technical issue with respect to mic. We will get it sorted out in 1 or 2 days time. Okay. So these are about malignancies, right? Commonly, solid tumors are likely to cause weight loss than the non-solid hematological malignancies. The mechanism is increased calorie demand because of the tumor activity and increased inflammatory cytokines which suppress appetite, which increase the basal metabolic rate. Okay. Then chronic inflammatory disorders like rheumatoid arthritis, patients with SLE, chronic kidney diseases, right? And then chronic infections. In India, you say, sir, patient with weight loss and some infection, first thing that comes to our mind is tuberculosis. The second thing that should come to our mind is HIV. Now, can anybody tell me what is the link between weight loss and infections or inflammatory disorders? So examples of chronic inflammatory disorders which can cause weight loss includes rheumatoid arthritis, SLE, right, chronic kidney disease or CKD, and then coming to infections, tuberculosis and HIV. Okay, so these are the causes for weight loss. What could be the mechanism here? What could be the mechanism for weight loss in chronic inflammatory disorders and infections? Again, the answer is same. Mechanism number 1, there will be increased inflammatory cytokines. Inflammatory cytokines like interleukin 1 and interleukin 6. They play a very important role in causing the cachexia. For a patient with CKD, there is an additional mechanism. Can anybody tell me the mechanism? Yes, all of them can cause anemia of CKD sub-zero. Same, inflammatory cytokines, interleukin 1, interleukin 6, as you know from iron metabolism, they can inhibit the ferroportin and thus reduce iron absorption. They can have direct suppressive effect on the bone marrow, and that contributes to anemia of chronic diseases. So anything, yeah, you're absolutely right. Anything that causes anemia of chronic disease can also cause weight loss. CKD, yes, protein loss, right. There is another important mechanism. See, can anybody list me the important functions of kidneys? What all functions kidneys do for us? One, they will help us to regulate the body water content. If there is excess water, they will throw out in urine. If there is less water, they will make the urine concentrated and conserve more water. Agreed. They play an important role in the regulation of potassium. If there is a problem with kidney, our blood potassium level increases. They play an important role in regulation of acid-base balance, right? So if there is a kidney disorder, we develop metabolic acidosis. Equally important is that they play a role in the metabolism of nitrogenous waste. Now whenever we take, yes, erythropoietin is another important one, ion regulation like sodium, potassium, chloride, bicarbonate regulation. They produce erythropoietin, thus they contribute to the regulation of hemoglobin levels. And equally important is that they play the most important role in the regulation of nitrogenous waste. So when we take protein, right, ultimately they are broken down to amino acids. We will absorb the amino acids, use them for building the other protein blocks, and some amino acids are used for synthesis of other substances, like for example, tyrosine is used for synthesis of thyroid hormone, dopamine, adrenaline, noradrenaline. But eventually, when we break down the proteins or amino acids are in excess, it is all nitrogenous waste, right? So what do we do with them? It gets converted into ammonia. The end product of the metabolism of nitrogenous waste is ammonia. This ammonia is toxic to brain, right? So, and it is also toxic to other cells. So this needs to be eliminated from body, and unfortunately, our kidney cannot excrete ammonia efficiently. So liver takes the responsibility of converting this ammonia to urea with what you call as urea cycle. So ammonia gets converted to urea through urea cycle, and that urea is eliminated by kidneys, right? But what if urea accumulates in the blood? What all problems it can lead to? Sub-zero, absolutely right. It helps us in conversion of calcidiol to calcitriol, or inactive vitamin D to active vitamin D, which is essential for absorption of calcium in the GIT. Urea, does it have anything to do with the weight loss? Uremia, right? Uremia decreases appetite, right? Uremia causes severe nausea and vomiting. So because of that, most of the patients with CKD, when they have very high urea level, they absolutely refuse to eat food. And in fact, if a patient with CKD reaches a point where his intake of food has reduced, we have to put him on dialysis, because the only way I can bring that urea out from human body is through dialysis. For potassium, fluid, for all other things that kidney do, we have alternate mechanisms. For example, potassium level is high, I can give calcium gluconate, I can give dextrose with insulin, which can reduce the potassium level. If body fluid level is high, I can still try to push kidneys work more by giving diuretics. If there is an acid-base disorder and there is metabolic acidosis, I can give bicarbonate. But once the urea is high, nothing I can do. Only thing I can do is to do dialysis to remove it. So if urea has reached a point where patient starts losing weight, it is an indication for dialysis. Okay, clear? Now, certain metabolic disorders also can cause weight loss. So can anybody tell me which metabolic disorders can cause weight loss? Or in other words, I would say endocrine disorders. Let me make it simple. Endocrine disorders. Sudhapa Samantha, yes, I am going to HIV syndrome again. Yeah. Which metabolic disorders can cause weight loss? Okay, I'll give you a clue. This is one disorder which you classically recognize with 3P symptoms. Those 3P symptoms are polyuria, polyphagia, polydipsia. Absolutely right. Diabetes and hyperthyroidism, right? So these are the two disorders, diabetes and hyperthyroidism, diabetes mellitus, hyperthyroidism, and if you have glucagonoma, these can cause weight loss. Okay. Now can anybody explain me why do we get those 3 P's in diabetes? Why do we have polyuria? Why do we have polyphagia? And why do we have polydipsia? All your answers are right, so you're bang on target. Now tell me, why do we get polyuria, polyphagia and polydipsia in diabetics? If I ask you to tell me what is the function of insulin, what will you say? First thing you will say is, sir, it regulates blood glucose level. Agreed. We need to regulate our blood glucose level in the range of 70 to 120 milligrams per deciliter. Insulin plays a crucial role. But more important than that, insulin is required for the utilization of glucose by tissues. So if there is lack of insulin or if there is insulin resistance, tissues can't use glucose. So if my tissues are not able to use glucose, what is the signal that they will send to my body saying that I am craving for glucose, I don't have sufficient glucose inside me, right? All the tissue cells will say that I'm not getting sufficient glucose. So the signal that body is getting that there is inadequate glucose. That is how these patients start feeling hungry and start craving for food. Okay. Second, why do they get polyuria? Because glucose is an osmotically active substance. If you go back to your physiology books and look at the formula for serum osmolality, the formula for serum osmolality goes like this. Serum osmolality equal to 2 into serum sodium levels plus serum glucose level divided by 18 plus blood urea nitrogen divided by 2.8. This is our formula for calculation of serum osmolality. So now tell me, what are the major contributors for serum osmolality? Sodium is 1, glucose is 1 and urea is 1. So glucose is an osmotically active substance. And whenever we have a higher concentration of an osmotically active substance in some compartment, it will always drag water. So if our blood glucose level is high, we will start excreting large quantity of glucose in urine, and you know that is why we check urine glucose in screening for diabetes, right? So if I am losing glucose, I am not going to lose glucose alone, I will lose water also. That is how these patients develop polyuria, because they are losing glucose, with that they are losing water also, because glucose is an osmotically active substance. It will not go alone, it will drag water along with it. And if I start losing water, I am getting dehydrated, and when I am getting dehydrated, there is a thirst center in the hypothalamus that will get activated, and that will send the signal to me that okay, I am thirsty, I need to drink more. So this is how they develop polyphagia. Polyphagia because tissues are not able to utilize glucose, that's why they need to eat more. Polyuria because they are losing glucose in urine, and with that they are losing water. And polydipsia because when they lose water, they become dehydrated and activate the thirst center, and that is why they drink a lot of water. Okay, good. And if I am losing glucose in urine, what will happen? I am losing calories, so obviously I will lose weight. Simple, right? Now why do we get weight loss in hyperthyroidism? All of you pointed it out, absolutely right. One stands for blood urea nitrogen. Blood urea nitrogen. Okay. Why do we lose weight in hyperthyroidism? Tell me one major function of thyroid hormone. Right. Thyroid hormone plays an important role in regulating the basal metabolic rate. What is basal metabolic rate? When I am not physically doing any major activity, still my body is burning calories, because there are a lot of active processes in the body, right? Lot of absorption in the GIT, lot of reabsorption in the kidneys, lot of excretion of molecules, conduction of electrical impulse through neurons. They are all active processes which require ATP. And how do we generate ATP? By burning glucose, right? We convert glucose to ATP, and that ATP is spent as the energy currency. So even when I am just sitting quiet, my body is burning calories, right? Now, when we are at rest, whatever calories we burn, that is what we refer to as basal metabolic rate. In addition to that, depending on our physical activities, we will burn more calories. I work out more, I do a lot of physical activities, I will definitely burn more calories. If not, even if I am absolutely staying like a log of food, no physical movements, I will be still burning calories, and that is what we refer to basal metabolic rate. And that is decided by the thyroid hormone. More the thyroid hormone in the blood, more is the basal metabolic rate. That means even at rest, our body is burning a lot of calories. So when we develop hypothyroidism, what happens? Our basal metabolic rate decreases. So our body starts burning less and less calories. That is why hypothyroid patients develop weight gain. But once we have hyperthyroidism, basal metabolic rate increases, we burn a lot of calories, And because we are burning a lot of calories, we will lose weight. And because we are burning a lot of calories, we are generating a lot of heat. See, when we burn calories to generate ATP, we dissipate a lot of heat, and that is why patients with hyperthyroidism are intolerant to heat, because already body temperature is soaring. Okay, so the mechanism for diabetes mellitus is there is increased glucoseuria, and the mechanism for hyperthyroidism, there is increase in the basal metabolic rate. Okay, glucagonoma refers to tumors which secrete glucagon. We know that there is an insulin as a hormone which decreases the blood glucose level, but whenever blood glucose level decreases to a low threshold, lesser than 70 milligrams per deciliter, body secretes another hormone from the pancreas called as glucagon, which increases the blood glucose level, right? Now, if I have a tumor which produces glucagon, what it will do? It will stimulate all the tissues to increase the blood glucose level. How tissues will be able to increase if I am not eating more? They have to mobilize fat, muscle and glycogen to create glucose, right? So I start losing fat, I start losing muscle, and I start losing the glycogen store, and that is how I end up losing weight, right? So the underlying mechanism is there is increased production of glucagon. Okay, so these are all metabolic disorders where we can experience weight loss. Okay. Apart from that, there are a lot of psychiatric disorders which I will leave it to my psychiatric colleague to talk about, where there are eating disorders and other behavioral disorders where patients tend to lose weight as well as gain weight. So these are our concerns, right? So whenever a patient presents with unintentional weight loss, these are the possibilities. There can be an underlying malignancy. Patient may be going through chronic inflammatory or infectious disorders. Patient may be a case of a metabolic disorder or may be having psychiatric issues, right? Now, in the exam, what questions they will ask you? Bedside discussion, the first question you will face is whether this weight loss is clinically important or not, which objectively you should know this definition. In the MCQs, they will ask you the underlying mechanisms for weight loss. The mechanism for weight loss in cancer is increased calorie demand and increased inflammatory cytokines. The mechanism of weight loss in most of the chronic inflammatory and infectious disorders is increased inflammatory cytokines. An additional mechanism, that is uremia in patients with CKD, that decreases appetite and causes nausea and vomiting. The mechanisms underlying metabolic disorders causing weight loss is different, which we discussed. Clear? Okay. Now, before I move forward, we need to understand one more extra relevant term which is called as HIV wasting syndrome. Now, what happens in patients with HIV? First of all, sitting in India, if anybody asks you to give 10 causes for any symptom for that matter, right? You can always place HIV at the bottom saying that HIV can also cause. HIV is one of the great masquerader or mimicker. Can HIV cause muscle disorder? Yes. Can HIV cause encephalopathy? Yes. Can HIV contribute to meningitis? Yes. Can HIV contribute to the development of tuberculosis? Yes. Can HIV cause weight loss? Yes. Can HIV cause chronic diarrhea? Yes. Can HIV cause acute febrile illness? Yes. So HIV figures in everything, and you can always mention HIV at the bottom of any disease that you're talking about when it comes to infections or chronic inflammation. Okay, now before I go into HIV wasting syndrome, I'll ask you one question. If a patient walks up to you and say that, sir, I have a family history of cancer, and if I develop cancer, can I increase my chances of survival? Apart from early detection, screening and all that, is there anything I can do so that if I develop cancer, my chance of survival increases? What would you answer? The single best intervention that can increase the chance of survival in a patient with cancer. I think I have already told you that 1 in 5 cancer patients die because of cancer cachexia, which is nothing but cancer-induced weight loss. Rishabh Bhagat, you can pin your query. I will definitely answer that. So question is simple. I hope you are able to understand. Tell me about something that reduces the risk of death once you develop cancer. Sutapa Samantha, you are somewhat correct. See, 4 out of 5 patients, 4 of them die once they develop cancer because cancer spreads to other organs and causes the dysfunction of other organs, which can only be controlled if we recognize cancer early before it starts spreading, right? But if it has already spread, then either organ dysfunction will kill the person or it is the cachexia, right? So from spreading to the other organs, we can only reduce the risk by early detection and maybe with the help of chemotherapy, radiotherapy. What can help us to reduce the risk of mortality when patients are going to develop cachexia? Simple. What happens in cachexia? Your tumor cells need a lot of calories. So whatever you eat is all taken up by tumor cells and your body is deprived of nutrition, right? So slowly, indirectly we say that your tumor cells eat you up. Slowly it is eating your energy reserve, drying you out and growing itself. And eventually you lose your muscle mass, you lose your bone strength and you die out of it. But if I develop cancer already having a well-built body, my chances of long-term survival is high because it will take longer time for the tumor to eat me up. And that is why nowadays we say that having a good protein intake, maintaining a good lean muscle mass, or indirectly saying going to gym reduces your risk of developing deaths because of cancer. That's the single most important intervention today. But again, I'm telling you that if you go to gym and start taking anabolic steroids and all nasty supplements, your risk of developing cancers because of them can increase. But otherwise, as long as you're eating healthy and do some physical activity to maintain a higher muscle mass, your chances of death, even when you develop cancer, comes down. Okay. Krishna Rathod, that's a very important point. There's something called as calorie restriction. So if we reduce our calorie intake by 30%, we achieve longevity overall, not just the cancer. Overall, we are likely to live longer if our calorie intake is lower than having a higher calorie intake. And that goes without saying that in India today, most of us are eating more than we need and slowly becoming obese. It starts in the MBBS. By the time you become PG, you will start noticing that there is a pot belly. And by the time you finish PG, you fit into the criteria to be called as obese. Okay. Anyway, now coming to this topic, HIV wasting syndrome. What is HIV wasting syndrome? HIV is a chronic infection, as we know, and in HIV also there is upregulation of inflammatory cytokines like interleukin 1, interleukin 6, interleukin 8, and these inflammatory cytokines suppress appetite, increase metabolic rate, and that is why your tissues need more glucose, more calories. So they will burn a lot of calories and we tend to lose weight. And this is also one of the reason for death today. See, today, because we have highly effective antiretroviral therapy, we have achieved a good control on the opportunistic infections. And even when opportunistic infections happen, we have effective drugs. So most of the times we will be able to fight it out and bring the patient out of the death's loop. But if he starts losing weight, then there is nothing much we can do. We might end up losing the patient, right? So a person living with HIV, PLHIV is a modern term used for describing person living with HIV. Instead of saying that HIV positive patient, HIV negative individual, we use the term person living with HIV. If they lose more than 10% of their body weight over 12 months or more than 5% of their body weight over 6 months, we call it as HIV wasting syndrome. And we should remember that HIV wasting syndrome is an AIDS defining illness. It's an AIDS defining illness. Means what? If there is a person living with HIV and he loses this much weight, now you can call him as having AIDS. Now you can call him as having AIDS. There are other disorders like if an HIV individual develops cryptococcal meningitis, pneumocystis carinii pneumonia, right? Then we will call them as having AIDS. HIV and AIDS are not equal. There are a lot of people who develop HIV, but they will be able to live quite a normal life without developing opportunistic infections or any major untoward effects by being on antiretroviral therapies. So we will not label all of them as having AIDS. AIDS means HIV leading to certain critical opportunistic infections or complications. One of them is this HIV wasting syndrome. Okay, good. Okay, I will address that. Now, the last bit for discussion today is how to assess a person presenting with unintentional weight loss. First and foremost is we should spend more time on looking for potential clues in the history for an underlying cause. Like for example, I come to you and say that, sir, in last 3 months I have lost 15 kgs of weight and I'm really worried about it, right? Then you will start taking the history. In the history, you will definitely ask me whether I have polyuria, whether I have polydipsia, whether I have polyphagia. If I say yes, then you know you may be seeing a patient with diabetes. So in that case, you will ask me to get the HbA1c, fasting and postprandial blood glucose levels, and then you can recognize it as diabetes. Similarly, if I say that I've been coughing for last 3 weeks, you know that it is a subacute cough, and in India we should always think of tuberculosis. Similarly, if I say that I've been bleeding in my stool, then you can start thinking of maybe I'm having a GIT malignancy, right? Maybe a colon cancer, maybe a cancer of the stomach. Or if I start saying that I have hemoptysis, I'm coughing out blood, then you can start thinking that maybe I'm having the carcinoma of the lung. Without looking for potential clues in the history, sky is the only limit for the investigations. I need to investigate top to bottom, maybe a PET scan of the whole body, and then I might get some clue. But otherwise, if you're good in taking history, you will get some potential clues and your direction of investigation goes in that direction, right? So spend some time to get some clues in the history and also an examination that will help you to lead further. And after your completed history and examination, anthropometric measurements are important. And when it comes to anthropometric measurements, today what is recommended is basal metabolic, body mass index, right? Body mass index. Can anybody tell me what is the formula for body mass index? UWL stands for unintentional weight loss. Okay, so can anybody tell me the formula for body mass index? Rishabh Bhagat, I will address your query. See, there are two things, Rishabh Bhagat. If your concepts are clear and you're done with the previous questions, as long as you're aiming for a rank of within 5,000, it should be easily possible. If you're aiming for a rank within 1,000, obviously that is not adequate. And at the same time, if your basics are not sound, then just doing PYQs is not enough. If your goal is to get somewhere around 10,000 to 15,000, PYTs will be able to help you reach there as long as you spend sufficient time on the previous year topics. But if your goal is like, okay, I just want to qualify NEET, then PYQs and little bit of logics, you may be able to qualify. Right. So basal body mass index is defined as weight in kilograms divided by height in meter square, right? Height in meter square. Okay. Now, what is the cutoff to say that patient has got underweight? And when do you say that patient has got overweight? And when do you say it is obesity? When do you call it as underweight? When do you call it as overweight? And when do you call it as obesity? Right, Bhumika, absolutely right. So when BMI is less than 18, you can count it as underweight. So any HIV patient with a BMI less than 18 by default is having AIDS wasting syndrome, and thus we will the HIV wasting syndrome, and thus we can label him as having AIDS. Anthropometry basically means measurements, taking body measurements of different body parameters. The most commonly used in adults is the body mass index. In pediatrics, you have other measurements. You can also look at the fat pad thickness. You can look at the mid-arm circumference. There are various other measurements that are usually taken in pediatrics. In adults, BMI is more than enough because we would have already reached our full height. Okay. So more than 25, we call it as overweight. And when it is, guidelines differ slightly. Roughly speaking, 25 plus, you can count it as overweight. And when it is more than or equal to 30, you can consider it as obese or obesity. We can consider it as obesity. Cachexia is a term used to, it includes two things. One, weight loss, and when we refer to weight loss, we are talking about lean body weight loss. When I say lean body means what? The muscle and the bone weight, not the fat loss. Fat loss is good for human body. So if someone just like that starts losing fat, we wouldn't say that it is a big concern. So when we say cachexia, it means patient has lost weight, and within that lost weight, there is a loss of muscle mass. Then we will call it as cachexia. That can happen because of HIV. That can happen because of cancers. Cancers are the leading cause for cachexia. Okay, so we will measure the anthropometry, and then we have to do some basic blood investigations. What are the blood investigations important for us? I will do a complete blood count. Can anybody tell me what is the relevance of doing a complete blood count in a patient presenting with weight loss, unintentional weight loss? Complete blood count. I will do renal function tests. I will do liver function tests. Okay, I will do a minimum chest X-ray and I will do an abdominal ultrasound. These are the first line investigations. Apart from that, I will do an HbA1c. Bone marrow is not a first line investigation until and unless in the initial evaluation I have found some potential clue which suggests that it may be a hematological malignancy. Probably I don't need to go for the bone marrow. But yeah, if I get some clues on the CBC saying that okay, I am suspecting that okay, there are blast cells present, I am thinking of a hematological malignancy, maybe then I will go for bone marrow. Right, yes. So complete blood count tells me about two things. Number one, if there are chronic infections, the complete blood counts may be altered. You may have neutrophilia, neutropenia, lymphocytopenia or lymphocytophilia. Second, anemia, right? Weight loss can also be because of the nutritional deficiency, right? Not so common today, but it was very common 10-15 years ago where our country's economy was not that great and poverty was still a concern. It's still a concern, but it has come down significantly. In the recent times, I have not seen patients presenting with weight loss because they could not afford meal. It's still a possibility, right? Such patients often will be anemic. So anemia may be a pointer towards nutritional deficiency. I am doing renal function test mainly to identify whether he is having an impaired renal functions, because CKD with uremia can also contribute to weight loss, right? Then I am doing LFT. Why am I doing LFT? My main concern is to look at the albumin levels, because albumin is a protein synthesized by liver and it indirectly tells us about the nutrition. If the patient is nutritionally compromised, serum albumin levels will be low, just like what you see in patients with protein energy malnutrition in pediatrics. So if there is a low serum albumin, it tells me that patient may be having nutritional deficiencies. I do chest X-ray because it might hold a clue towards an underlying malignancy or tuberculosis. And if I have to look, yes, even liver cirrhosis contributes to weight loss. That also I can gauge from the LFT. Okay, chest X-ray for two reasons, a cancer of the lung and tuberculosis. And if I have to look for tuberculosis, which lobe of the lung I should concentrate on? Which lobe is important? What is the most common site for the tuberculosis of the lungs? Bhumika, not perfectly right. Remember, tuberculosis, as you study from microbiology, the bacteria is a facultative aerobic organism. It's a aerobic organism. So it needs air. So it will dwell or grow in areas which are well ventilated or well aerated. And upper lobe is the one which receives more air compared to lower lobe. So that is why tubercle bacilli prefer to inhabit the upper lobes. And right upper lobe is the most common site to look for tuberculosis, where you can see Gons focus. And if it is an active tuberculosis, you might as well see a cavity. In the subsequent sessions, we will go through some images where tuberculosis patients had beautiful cavities. Okay, right apical lobe. Then abdominal ultrasound mainly to look for any GI malignancies, right? Malignancies originating from the stomach, pancreas, liver, hepatobiliary tree can easily be identified with the abdominal ultrasound, and I will be doing an HbA1c to understand whether patient is having diabetes. Now my question is, why am I choosing HbA1c over other blood measures, right? I can also do urine sugar, I can also do FBS, I can also do PPBS. Why am I preferring HbA1c? Amit Patra, hi. Why HbA1c? Why not FBS? Why not PPBS? Why not random blood sugar? Sutapa Samantha, Gons focus refers to the first site where the tubercle bacilli got inoculated and body tries to contain the spread of infection by creating granulomas around it. So that primary tuberculosis, first site of inoculation, is what we call as Gons focus. Because HbA1c tells us about the average blood glucose level, or what we call as MBG, mean blood glucose level of last 3 months or 12 weeks, as someone commented. Fasting and postprandial blood glucose levels are quite manipulable. For example, if I skip my previous dinner and then come for the fasting blood glucose level, it will be low. If I had previous dinner and then 8 hours of fasting and then you check MBBS, it may give me the true value. But patients can manipulate it by skipping the previous dinner. And similarly, when it comes to postprandial, do you think like if I go and eat like moong dal ka halwa and after that some nice Coca-Cola and lot of sugar, and another time I go and eat some salad, do you think both the times my postprandial blood glucose level is going to be same? No, right? First time when I ate too much of moong dal halwa, Coca-Cola, it will be high. Second time when I ate salad, it will be low. So it is easily manipulable. So for that reason, for the diagnosis of diabetes, we do something called as 75 gram oral glucose tolerance test. Means we give fixed quantity of carbohydrates and then check what happened to the sugars. We give 75 gram of glucose orally and check sugars. But it's a cumbersome procedure. Instead, in one sample of blood, I can get the HbA1c report also, and that is a fairly reliable reading, and that helps me to recognize whether patient is having diabetes. Okay, I will address about the weight gain also. Apart from these investigations, we might require some age and gender specific, and also I should have mentioned risk factor specific cancer screening. Age, gender and risk factor specific cancer screening, because we know that some gender are particularly prone for certain cancers. Similarly, some age group is prone for certain cancers. For example, I don't expect a 20-year-old to present with prostatic cancer, quite unlikely, right? But a 70-year person likely to have a prostatic cancer. So in such patients, the marker used for recognition of prostatic cancer is PSA. Just to give you examples, prostate specific antigen for elderly to recognize prostatic cancer. Okay. Similarly, a female, right, in their 40s are likely to have the cervical cancer. So in them, doing a pap smear and other investigations makes sense. Obviously, I shouldn't be doing a pap smear, or I shouldn't be asking for a pap smear for a male, not a disorder of the males, right? I guess all of you agree on this. Similarly, a smoker. See, I will be least thinking about the lung cancer in a patient who has never smoked, no passive smoking, no exposure to any other noxious gases. The lung cancer will be my last differential diagnosis. But for a person who has smoked for several years, lung cancer is a possibility, right? So in such patients, doing a screening HRCT scan of the lung makes sense, right? So you have markers for ovarian cancer, you have markers for the breast cancer, you have markers for prostate cancer. So for many cancers, we have markers. We will do them according to the age, gender and risk factors. Okay. So one last question for today. How do you assess the risk of lung cancer in a smoker? What is the parameter we can use? Amit Patra, we will be doing a session on approach to obesity, which is definitely going to be a very, very relevant session for all of us, because India right now is in the middle of a epidemic of obesity. You just scan around people and you will see that 1 in 2 are definitely overweight and 1 in 3 are obese. See, for every cancer, smoking or only one risk factor is not responsible. That's why you can also say that, sir, I have seen a lot of smokers. I had a grandfather who smoked for 50 years and he died because he slipped in the bathroom and he broke his femur. After that, he developed a DVT, developed the embolism and died, but he never had lung cancer. Well, possible, because only one risk factor as a cause for cancer, bit debatable. Other factors do contribute. The genetics is the biggest contributor after the lifestyle. No, we can't measure the nicotine levels. We can't. Gold criteria is mainly for assessing COPD, right? We measure the risk of developing lung cancers by measuring the smoking. Now, how do I quantify smoking? By calculating what is called as pack years, which is important for you. Because every time you get a patient who says that he has been smoking, you should calculate the pack years. Consider evaluation for lung cancer in smokers with more than 30 pack years. More than 30 pack years. Right. So what is the formula for pack years? I want you to remember today itself, because when you do this history taking, right, you ask them habits, and smoking and alcohol are so common. So you should know to quantify smoking, you should know to quantify alcohol intake. Right. So pack year, the formula goes like this. Pack year is equal to number of packs of cigarettes smoked per day. Number of packs of cigarettes smoked per day multiplied by, when I say smoked per day, this is the average, like average how many packets of cigarette you smoke per day, multiply that with the number of years the patient has been smoking, number of years smoked, and that gives you the pack years. Okay, so I will give you a small work now, just a small exercise. So I have a patient here who has been smoking 1 cigarette per day for last 10 years. So what is his pack years? Can anybody calculate? So guys, as a teacher, right, I am very observant, and whoever gives the right answer, I know your habits. 1 cigarette per day. I didn't say 1 packet per day, right? 1 cigarette per day. And the formula says number of packets or number of packs of cigarettes smoked per day. So Ujjwal Mishra says 0.1 into 10. Is that right? How many cigarettes will be there in 1 pack? See, if you give correct answer, you get caught. How many cigarettes will be there in 1 pack? Yeah, Indian pack, there are 10 cigarettes. But this pack year formula is an international formula, and international packs have 20 cigarettes, right? So please remember, 1 pack is equal to 20 cigarettes. 1 pack is equal to 20 cigarettes. So in that case, what will be the pack years here? So pack years for this example will be 1 cigarette per day means how many packs? 1 by 20 packs per day into 10. So that becomes 0.5 pack years. 0.5 pack years. So if this patient comes to me saying that, sir, I have lost weight, should I go for the lung cancer screening? Should I go for the lung cancer screening? No, right? Because typically the risk of lung cancer increases when patient has more than 30 pack years. So 2 epidemiological points to note here before we wind up, right? Risk of COPD increases after 15 pack years. 15 pack years. And risk of carcinoma of the lung increases after 30 pack years. Okay. So now I will just briefly take you through what Harrison has covered about this topic. I think we have addressed most of the points. Okay. So Harrison has defined what is clinically important weight loss, that is 10 pounds or more than 5% of the body weight over a period of 6 to 12 months. Okay. Then he will talk about the causes for unintentional weight loss. He does talk about the physiology of weight regulation, which is mainly in patients with unintentional weight loss. There are different mechanisms which we have discussed. Then he mentions the causes for unintentional weight loss. He also categorized them into 4 groups: malignant disorders, chronic inflammatory or infectious disorders, metabolic disorders, and psychiatric disorders. Okay. And he also mentions that most common malignant causes are mainly solid tumors like hepatobiliary, gastrointestinal, lung, breast, hematological, genitourinary, ovarian, and prostate, which we have already discussed. Okay. Then he puts out some points about the approach, and again he emphasizes, when he says approach, there should be a comprehensive history, because history will help us to narrow down our differential diagnosis, and then a good physical examination, same set of investigations I spoke about, CBC, LFT, right, and then the chest radiography, abdominal ultrasound, so same investigations we will do, keeping an objective outcome in mind. And then HIV testing for patients at risk. Okay, what is muscle mass? See, all of us have fixed, see, when I say I'm 70 kg, that means I may be having, you know, that major part of the 70 kg is water and the rest is solid components, which includes fat, calcium in bones, right, muscles, and the some amount of glycogen stored in different tissues, right. So now muscle mass is very, very important for us, because the more muscle mass we have, right, we have a longer life expectancy regardless of our other risk factors, and higher chance of survival if we develop cancer. So Samantha, that's what I told. See, genetics, when it comes to cancer, it is not only risk factors, genetics play an important role, right? Apart from smoking, there are other substances which are carcinogenic. For example, if you are working in an industry where there is exposure to asbestos, asbestos can also cause cancer. Similarly, if you are working in an industry where there is exposure to coal or silica, they are also carcinogenic. So smoking is not the only carcinogen. So people may be getting exposed to other carcinogens. Krishna Rathod, dehydration causes weight loss, but it generally causes acute weight loss. That is why we are not bothering about someone losing 2-3 kgs in 2-3 days time. It's always because of dehydration or blood loss, right? So that's why in the initial definition only, we have made sure that we give importance to chronic weight loss. My weight today is 70, tomorrow 66. Can't be because I lost fat, I lost muscle, I lost bone. It can't happen that way. Only I have to lose blood by bleeding, or I should get dehydrated, right? So in acute weight loss, it's not a major concern, and hydration will improve, and that gives the answer that okay, patient was dehydrated, that's why his weight was low. Now we have hydrated, his weight is back to normalcy. Okay, so this is what Harrison also talks about, the same approach we have discussed. Harrison spent some time on talking about the treatment of unintentional weight loss, which I am not getting into right now, because for every disorder we have different approach. If an HIV individual loses weight, how we should handle. If a CKD patient loses weight, how we should handle. It's all going to be different. So generalization is not good for us. So we will ignore this point and we will conclude our session today. So what we have learned today is, we have learned what counts as clinically important weight loss, what are the major causes for it, and when I take history, what I should be focusing on. And then for every patient of weight loss, I should be measuring the basal metabolic index, and I should have an idea about what are the common investigations that we should start with, right? And sometimes examiners do ask you, like, okay, given this patient, looking at his age or her age, gender, what are the cancers that come to your mind? We should always keep a list of malignancies in our mind every time you present a patient with weight loss for that particular age and gender group. For example, a woman in 40s, maybe like what cancers I can think of: breast cancer, ovarian cancer, cervical cancer, right? A male in 40s, I can think of lung cancer, stomach cancer, squamous cell carcinoma of the mouth, because he chews pan, tobacco, stuff. In their 60s, 70s, I can think of prostate cancer, right? I can think of other bone malignancies like multiple myeloma. So we should always make a small list of gender, age group, and the malignancies which are common. That is where the discussion on the weight loss ends. So from me, that's it today. Manpreet Singh, we have another session where we will be discussing the other habits. So we have a session primarily focused on history taking and the general physical examination. I will address how to gather the history of alcohol, how to compare different forms of alcohol, like wine, how much wine is equal to how much of beer, how much of beer is equal to how much of vodka, gin, rum, all that we will have a table. The word significant weight loss is the term used in the past. The same term has now been replaced with the clinically important weight loss. So in the past, we used to call it as significant weight loss. Now we have replaced that with the clinically important weight loss. This is all American locha, means Americans, for patient it may be symptomatic, for patient it may be significant, but for a clinician it need not be significant. So why should we use patient's terms? Patient may come to us with 2 kg weight loss, for him it may be significant. I do not want to disagree with him. He is being bothered by that 2 kg weight loss, but it is not clinically important. So we have replaced this term significant weight loss with clinically important weight loss. Okay, so guys, that's it for today. We will have the next session on 15th, and next session is important. Again, a very common complaint, that is hypoxia and cyanosis. So we'll learn how to assess hypoxia, how to utilize pulse oximetry, ABG, how to interpret ABG, as well as how to recognize and differentiate between central and peripheral cyanosis. So if you read and come, it will make it a bit easier, and we will also be taking some MCQs from today's session. So that's it from me today, guys. I'll be signing off, and I'll see you on the 15th, same time. Thank you, guys. All the best. Have a good time. Thank you.